Okay, is that better? Can you hear me now? Can everybody hear me? If you can, let me know. I'm still learning this. Bear with me. Hi, guys. I see everybody's here. Hi. Hopefully you can hear me now. If you can, let me know. I'm just going to get set up here. I'm not ready. This is so much tech, guys. I'm trying so hard here. So much tech. We're going to get it all worked out, though. Can you guys hear me? Yay! All right. We're good to go. All right, guys. Hi. It's Miss Patty with For Your CNA, and we're here every Thursday at 3 to answer your questions on CNA training, testing, workplace, whatever you have. We're here to help you with. So today, as usual, I know I'm running a little bit late, but we're trying something new with this new streaming software. And it's going to give me the ability to be able to do like on-screen graphics and stuff like that. It's really, really cool. But I have to learn it. So bear with me. We're trying to improve the experience for you guys. But before I get into your questions, I see we've got a lot of people here. That's awesome. Before I get into your questions, I actually had a email come in from somebody who's getting ready to test at the end of the week, and she had a couple of questions, and I thought that they were questions that really needed to be addressed here rather than me just sending her an email, because it's something that I think a lot of people are wondering about and questioning. So this came from Karen, and Karen says, I'm about to test at the end of the week. I've been watching the videos and feel more confident. Miss Patty is awesome, but I'm curious because my instructor has shown us different ways of doing some of the skills, and I'm worried now that I'll do them incorrectly. For example, she has us dressing a patient with a bad arm, putting on the shirt first, then the pants. She's also taught to use a paper towel every time to turn the water faucet on or off. And when they measure the urinary drainage bag, instead of using a chucks, they were instructed to use a paper towel under it. One other thing is when we do catheter care, we're instructed a little bit differently than your video shows. We were instructed to use, I think, one less washcloth. Will any of this have any bearing on our skills test? And then she goes on to explain one more thing that I think is just beautiful. She said, I'd really appreciate it if someone could let me know something. This is very important to me. And I want to make sure that my patients have a well-trained CNA helping them. And I absolutely love that. Her focus, although she wants to pass a test, it's very important to her. Her focus is actually a little bit bigger than that, wanting to make sure that she's got the right training to be able to effectively help her patients out in the workplace. So give me 1 second here. Still trying to figure all this out, guys. Hold up. Your comments are coming in fast and furious. Okay. So the answer to that is, there's a lot of answers to that. So I want to start out with the very first one. And she said that dressing a resident with a bad arm, and I'm going to stop there because this is something that's actually a little bit important. We can't call it bad. Okay, the patient can call it anything they want. Patient can call their arm George if they want to. That has no bearing on us. But when we are talking to the patient or about the patient, we want to use terms like weaker or affected, or even just right and left is okay, but we want to try to stay away from that bad term because there's a negative connotation to that. And it's not professional either, but we never want the patient to feel less than. So we don't use that term bad. Okay, I hope that helps. But the question is there, the patient has an affected arm. She was taught to put the shirt on first and then the pants. And I'm going to tell you, it really doesn't matter. Nobody cares. If you want to put the socks on first, that's fine. If you want to put the shirt on first, that's fine. If you want to put the pants on first, that's fine. Nobody cares. Where the order matters here is when we're working when we're actually putting the shirt on. So when we're working with that weaker or affected arm. So the thing that we use to remember this is USA first. Undress strong arm first. So USA first. And then we're going to dress the weak arm first. Now, the reason for this is because when you have an arm with limited mobility, we want the garment to just slide right off that arm, no movement really required. So if you make the stronger arm do all of the work, then the weaker arm doesn't really have to. So we're going to undress the stronger arm first and then dress the weaker arm first. But it doesn't matter whether you do the shirt first or the pants first or the socks first, however you want to do it. Now, the second question here is to use a paper towel every time to turn off or on the water faucet. Now, this is kind of going above and beyond, and I've actually seen a lot of instructors do this because it really is easier to train students to just use a paper towel for everything. But that's not really how you're tested. You can turn a faucet on without a paper towel as long as your hands are unclean, right? You can't touch a clean faucet with clean hands. That's the principle here. That's what you need to know. You can touch a dirty faucet with dirty hands. That's fine, but you can't touch a dirty faucet with clean hands. So you have to be aware every time you go to the sink, are my hands clean? Did I just wash them, or are they dirty? As long as you're aware of which is which, then you can kind of work out when you need a paper towel. So in order to get away from that, a lot of instructors say anytime you touch that faucet, just use a paper towel because the faucet's dirty. And that's fine. You can do that on the test, but it's not required. The only thing that's going to be graded on the test is if you have clean hands, did you touch that dirty faucet? So when you're done washing your hands, you're going to use a paper towel to turn it off. When you're getting water for a patient's use, after you've washed your hands and got your supplies, you're going to use a paper towel to turn it on. So clean hands can't touch a dirty faucet. If you remember that, that's the infection control principle here. If you don't want to remember that, or you're afraid you're not going to remember that, then just use a paper towel all the time. There's no problem with that. When you measure the urinary drainage bag using a chucks or a paper towel on the floor, doesn't matter. Nobody cares. It just says barrier. That's what the testing checklist says, is barrier. Did you use a barrier? And anything can be a barrier. So if you want to use a chucks, that's fine. If you want to use a paper towel, that's fine. But here's the problem. One of the checkpoints is you cannot carry an open container of urine through a room. It must be covered. So this is, when we take a bedpan out from under a patient and we're taking it to the bathroom, it's got to be covered. If you're taking a urinary triangular graduate container into the bathroom, it's got to be covered. And the paper towel just honestly doesn't really wrap around it very well. So it's hard to maintain that coverage when you're transporting. So the chucks really does kind of function in two different ways. It conceals what's in there, because guys, that's a privacy issue. Nobody needs to see what's in that cup. So it's a privacy issue, but it also covers it so that there's no accidental spilling. So you can use a paper towel if you want to, that's fine, but just remember that you probably want to grab two, one to cover it and one to go on top for transport. A chucks one will cover the whole thing. Catheter Care. Now, I can't really talk about this one too much. She said that they were taught to use one less washcloth. But the principle here is whatever we wash, we rinse. And the rinsing has to be done with a wet, soap-free washcloth. So I'm not real sure how the instructor taught you to do this with one less washcloth when you're, to avoid cross-contamination, you have to have a different washcloth to wash the peri area and wash the tubing. That has to be two different washcloths. And you can rinse the peri area and the tubing at the same time, I guess. I'm not real sure. That's kind of a gray area for me. I like keeping the two completely separate. And when we remember the principle, whatever we wash, we rinse, whatever we rinse, we dry. If we remember that, making it two separate areas really does kind of help with the flow. So what your teacher taught you to do may be perfectly okay, and it may pass the test no problem. I don't know. I didn't, see what you were taught. But I can tell you, as long as you can remember and apply whatever we wash, we rinse, whatever we rinse, we dry, and don't cross-contaminate by using that, same washcloth, you're probably okay with that. And okay, so I guess that's it. So I think I took care of all of that. So if you've got any questions like that on the state test, please drop by and let us know. We're here every Thursday from 9 to 1 every week, and we like to answer your questions. So if you have any, drop by and let us know. You can always send me an email, and if I can get to it, I may pull your question for a lesson as well. I hope that kind of helps. But we want to send Karen all kinds of good vibes for her test later this week, and we hope that you do fantastic. Please let us know how you do, okay? Please let us know. So let me go up here and see. Oh my goodness, there's lots of you today. Jennifer, hi. We missed you last week. Glad you came back. Lena, hi. RL. Sherry T, hello. Emily, hi. Nikara, hi. Hilda, hi. So let's see here. Jennifer has a question. What is the difference between a delusion and a hallucination? Well, Jennifer, it's kind of like saying, what's the difference between two different types of donuts? They're all mental manufacturing of images or sounds that aren't there. But the big difference between a hallucination and a delusion is in the application of it. So if I'm standing here and I see big giant spiders crawling on my wall, and there aren't really big spiders crawling on my wall, but my brain is telling me that there are, that's a hallucination. Seeing or hearing things that don't actually exist, that others can't see or hear, that's a hallucination. Now, a delusion can be visual or auditory, yes, but delusions are usually more internal. So it's not like I'm seeing the wall and seeing a spider that doesn't actually exist. A delusion is more that a deeply held belief that is not necessarily true. So if I believe that a spider in my room is the Spider King, and I have to do his bidding, that's a belief, right? The spider may not exist. That's the hallucination part. But the delusion is a belief or a deeply held kind of try to think of the word here, a deeply held opinion or belief or action that isn't necessarily true. And I have to caveat that, okay, because delusions can actually be very benign, where they don't really impact anybody else. Like, I may have a delusion that I'm have unlimited credit, and I go out and rack up my credit cards. So delusions can be kind of where they don't really, they're not really talked about. Don't really affect other people. But delusions can be progressed to the point that they're severe enough to alter the patient's ability to interact with society or to live a functional life. So delusions can kind of range on a scale from very mild all the way up to very detrimental to the patient's ongoing mental health. But a hallucination is something audio or visual that that other people can't experience. A delusion is more of a belief system. I hope I explained that well. So let's see who else is here. Okay, I've got somebody here. I can't, I'm so sorry, I can't pronounce that. It looks like it might be in Russian or Slavic of some sort. So hi, so MNP, hi. Missy, hello. And let's see here. Sophie is here from Kenya. Hi, Sophie. RL asks, when it comes to pain pills with dementia, does oxycodone increase dementia? That's a really deep question, RL. And I'm kind of hesitant to answer it. So I'm going to kind of answer it in a generic way. Any opioid can cause your inhibitions to be limited. Okay, it reduces your inhibitions. And if you are prone to any sort of a mental illness, it can exacerbate those mental illnesses because it reduces its inhibitions. Now, dementia, the term dementia just means something wrong with the brain. Broken brain. Okay, so if we have a broken bone, we call it a fracture. If we have a broken brain, it's dementia. Dementia can occur from a lot of different reasons. And it's a little bit different than mental illness, but dementia just means there's a physiological problem with the brain, either Alzheimer's or Jacobson-Crutchfield or Lewy body or Parkinson's or multi-infarct. There's a reason, but structurally speaking, the brain is not operating properly. So, because our inhibitions are managed by our brain and the opioids drop those inhibitions, you can end up with a lot of additional issues with dementia when you add in opioids. So that's going to be a purely individual response. There's some people with dementia that can take opioids with no problem. There's other patients with dementia that take opioids and have a catastrophic reaction to it. So it's very, very individual. There's no one answer that can fit all of that. But opioids really should be used with caution. It also should be noted that because of the propensity for addiction as well, with dementia, you may not have those reasoning centers to be able to understand when you're not able to, to get that pain relief where the pain is coming from, and that can have a catastrophic reaction as well. So opioids should be used with caution with people with dementia, but that's going to be a completely individual decision between the treatment team and the patient and their family and caregivers. So there's no one size fits all answer there. Jennifer says, if I got on Facebook and said I had a 94-year-old patient today and I just loved her and learned so much about her, would this be considered a HIPAA violation? What if I don't say her name? Oh, okay, so let's talk about this because this actually has been making news, national news, over the last couple of weeks. And it all basically was, there was a nurse that got onto social media and was kind of expressing her opinion and her view on some of the procedures that had happened. And she didn't use names or identifying characteristics, but it still came off as kind of a violation. So there's a lot of talk right now about how to manage a healthcare career and social media expectations when you have HIPAA sitting right in the middle of those two. So let's talk about it. So when it comes to social media, your best option is not to discuss anything related to your patients at all. And the reason is because you're always going to portray it from your point of view, right? It's your social media, your thoughts, your feelings, your experiences. It's all about you. But the problem is that who you're talking about is not you. It's somebody else. And they probably didn't give you permission to be talking about them. So to put this into context, let's change it a little bit. Let's say it's not a patient. Okay, let's change the roles so that you can kind of see this. And this is what I talk to my students about. If you had a best friend who is going through a heartbreaking situation, they had maybe just found out that they had a terminal illness and they were trying to come to terms with it, and that their loved one walked out on them, and they've got a child they're trying to figure out what to do about. I mean, that their life literally imploded. There is nothing going right, and they've confided in you, and they've poured out their heart to you, and this is a very personal, private thing between you and your best friend, and then you turn around and you put on Facebook everything that person is going through when they did not want it broadcast out. Does that make you a good friend? Well, no, it doesn't, because they told you something in confidence. They were turning to you for support, for a role that you were expected to fill, and then you broke that confidence by going out and broadcasting it to people that had no need to know. And of course, in social media world, everybody has an opinion, and everybody is not afraid to wield that opinion. So now your best friend has got all kinds of people saying, well, you should try this, or you should go do that, or, and that's not what she needs right now. She's still trying to cope. Well, we can all agree this is a bad situation, right? Well, this is not a good friend. This is not something you should do. So why do we change the parameters when we're talking about work, right? So when you are a caregiver working with a patient, everything that you see, hear, feel, whatever, that is between you and the patient. You do not have the right to go out and broadcast it to a random group of strangers that have absolutely no bearing on the situation at all. So when we kind of think about it in those terms, you're there being paid to do a job with this individual. Everything that happens in the confines of that really should be personal between you and them, and it should not be broadcast. Now, do I really think that there's a problem with you going online and saying you met a really nice 94-year-old today, and, I loved so much and learned, loved her so much, learned a lot, whatever. Do I think there's a problem with that? Probably not. Probably not. But do you really need to? I mean, would I really meet somebody in line at, Target and then go online to tell everybody in the world about my conversation with this stranger? I probably wouldn't, because there's no real need to. And I don't know what her situation is. And I don't know how that's going to affect her. So let me spin this on you just a little bit so you can kind of see it from the other point of view. So you go online and you remark, hey, I met this fantastic 94-year-old today. She's awesome. I just fell in love with her, whatever. And her daughter, who is estranged from her and doesn't have a relationship, happens to see that post because you have a mutual friend that you knew nothing about. And the daughter reads that, knows exactly who you're talking about, and now she is feeling horrible because who are you, this stranger, to come in, and you don't know her mom, and and I'm estranged from her, and it can bring up a lot of problems. So it's best to keep work at work and personal. Whatever's happening to you, feel free to share that with your social group. But work really does need to be work. We really don't need to be blurring the lines there. And if you are experiencing things at work that you need some social support from, okay, let's say that you've had a very traumatic experience. You had a patient that you were very close to that passed away. Social media is not the place to go to get your support for that type of situation. Social media will not be able to help you through that. That is going to require grief counseling. So you need to get with hospice and get into a grief counseling session, or you need to talk to the ethics person at your particular facility, or you need to talk to coworkers within your little bubble that can truly understand and support you as you're going through those types of issues. Social media is not going to provide you the support that you're looking for. So when you kind of look at all of that together, there's absolutely no reason that anybody on social media should know anything about your work environment. That is not where you need to be venting. And I understand healthcare workers need to vent. It's a tough job. I absolutely get it. I understand. But social media is not the place to do that, because you're not going to get the right feedback that you're looking for anyway. You're looking for a sympathetic ear, somebody that can commiserate, somebody that understands where you're at, that can be empathetic, that can help you process whatever it is that you're trying to process. The random strangers you have on social media are not those people. That is not what they're going to do. So if you're not going to get the benefit out of it, then why take the risk? I hope that helps. Hi, Sherry T from Dubai. Hello. Maddie says, hi, I test tomorrow and I love your videos. Oh, thank you, Maddie. Oh, great vibes out to you, Maddie. You're going to test tomorrow. Oh, we're going to keep our fingers crossed. Let us know how you do. I noticed in a lot of the videos you set the basin in the sink before drying it. I'm a little confused. Is the sink considered clean? Oh, it's a great question, Maddie. And it doesn't have an easy answer. Okay, so let me try to explain this as briefly as I can. This is a condensed version of a lecture I give in class. But for the test, you are simply going to rinse, dry, and store everything you use. And that's the way it is in a clinical setting most of the time, because that basin is only used by that patient, right? We're not passing basins out person to person. These are all single patient use items. So it's like your sink at home. You brush your teeth, you rinse your sink out. So all we're doing is rinsing, drying, and storing these items, and that's what you're going to do for the test. There is no disinfection required for the test, but there's going to be some settings you work in where we do have to disinfect. Like if you're working in an oncology ward where patients are on chemotherapy, or you're working with HIV positive patients, or you're working with on a burn unit, or you're working with neonatal intensive care. You want to make sure that, everything that we store is very clean, right? And rinsing and drying it is not enough. We want to disinfect it. So the process is exactly the same. So we rinse it, we set it down. And if you're going to disinfect it, that's when you would do it. Because you can't hold something with a dirty hand or dirty glove and disinfect it at the same time. In order to disinfect, you have to actually be hands off. The only place we have to put it is in the sink. Now, here's an infection control principle you probably didn't know. The bottom of anything in medicine is not considered clean. So the bottom of the basin resting on the sink is not a problem because it's not considered clean. And that's just a basic nursing principle. The bottom of anything is not clean. It's only what's up that's considered clean. And that's why we use a different paper towel to dry the inside. We're going to throw that paper towel away, and then a different paper towel to dry the outside, because remember, the outside is not clean. I hope that helps you. But it's one process, but it's going to be used for both rinse, dry, and store, and disinfection. But I teach one way so that if you're going to put the disinfection in there, you know where, but you're not going to require it for the test. Okay? I hope that helps. So let's see here. Kiddist says hello. Hi. Jennifer says, I wish there was a class out on only how to transfer people. I don't think the CNA classes go through how to do it very much. It's a great observation, Jennifer. And the problem is with transferring is that every patient is going to be different. And it's virtually impossible to have a class that would teach you everything, every situation you're ever going to encounter, because every patient's going to be different. So if we have a patient who is let's say has Parkinson's and is unable to take steps, right? They can stand, they can support their weight, but they just can't lift their feet up to take steps. That transfer is going to be completely different than a patient that has total right-sided paralysis from a stroke. So even though the process is the same, right? We're lifting the patient up, turning them, and going to sit them down in the wheelchair. The process is the same. Their level of ability is totally different. So that's going to affect how we actually do the transfer. So let's go on maybe to somebody with an amputation. That's going to be handled differently. Somebody that's using a slide board is going to be handled differently. Mechanical lifts, sit-to-stand lifts, moving a patient in bed with a draw sheet. All of those things are going to be handled a little bit differently based on the patient that we're working with. So it's really hard to have a class that would cover all of those scenarios. It really has to be patient specific wherever you're working. So, and that's part of getting to know your patients as well. So during your orientation period, you should be trained on those things with those particular patients if you're working in long-term care. And if you're working in acute care like hospitals and rehabs, you'll be working closely with the nurses and PTs to make sure that you understand the limitations of the patients. Hope that helps. It's me, Danny, LOL. Hi. That's a cute name. Lena says, hi, Miss Patty. Is Iowa State under Prometrics or Credentia? Lena, I'm not sure. My information is probably about 6 months old. I haven't looked at the testing, which states are using which testing companies in about 6 months. So my information is old. But 6 months ago, Iowa was kind of up in the air. There's 3 states that actually have multiple testing agencies within the state. So every other state, it's decided at the state level, but there's 3 states, and Iowa is one of them, that the testing center that was being used was up to some other process. That, you know, there were 2 testing centers in that state. And as far as I remember, Iowa was one of those that the testing center was a little bit ambiguous. I think it depends on where you're testing. I wish I could give you more information on it, and unfortunately I don't have time to research that right now. You can call the Iowa Board of Nursing to get detailed information about the CNA testing processes in your state. Let's see here. Bettina, hi. Hi, Henry. Beverly says, hi, Miss Patty. You have been a great influence on me passing my CNA exams last Monday. Oh, congratulations, Beverly. I'm so proud of you. Welcome to healthcare and great job. Hey, Blue. Thanks for coming. Hi, Sophia. Najo Chikuda says, hi, thanks you for your time. I have a question. Does a CNA exam on paper or computer? If it's on computer, do you get the chance to change an answer or once you answer it? Yes, actually, very good question. So in most states, I do believe there is one state that's still allowing pen and paper, but most states are now computerized. And when you're taking the test, so one question will show up on the screen. It's not like a whole list of questions. One question at a time shows up. You have your question, your 4 answer choices, you make your decision, and then you hit next. And at the end, there's a summary. So it'll actually show you all the the question numbers, and it'll show you that each one has been answered. You can click on any of those at any time and go back and review it to make sure that you answered it correctly. So yes, there is an opportunity to go back and change your answers, but I'm going to warn you on this one. Generally speaking, your first instinct is correct. Unless you have an absolute no question about it, I have to change this answer, I was wrong reaction, don't change it. Okay? So be really careful, because usually your first instinct is right. But yes, you can go back through and review all of your answers. You generally have 90 minutes to do 60 questions, so there's plenty of time there. Don't rush. you have time, but I would think really, really hard about changing answers. Your first instinct usually is right. So let's see here. Oh, you're welcome, RL. Blue says, oh, the world of HIPAA violations. The world of HIPAA is, oh boy, a headache, a very gray area. I agree, Blue, it is. But if you just go with, what I told you, personal can be shared, work is work, you're getting paid to be there, whatever's happening there needs to stay there. You're not getting paid to take it outside. So if you just kind of remember that and get used to not sharing anything about work on your social media, and there's no reason to, there is absolutely no reason to, no reason at all. Remember, your support does not come from social media. As long as you can remember that, HIPAA becomes really easy, really easy. Let's see here. April asks, how do I contact you personally? Just go to my website, foryourcna.com. It's the number 4. Here, I'll type it in for you. foryourcna.com. I've got to contact us. You can just send me a message through there. And let's see here. Desiree takes an exam on Monday. What should I remember? Oh, I don't have time for all of that, Desiree. That's a really big topic. But the written test is covering 5 main areas. Okay, so if you've got a pen, you can always watch this on the replay too. Know your role. Remember, CNAs, we as CNAs do routine tasks on stable patients according to the care plan. That's it. Follow that statement. That is the most important statement in the CNA world. Routine tasks on stable patients according to the care plan. You also have to know your normals, normal vital signs, but also normal changes of aging, normal for disease processes, know your normals. Because a big part of CNA is reporting abnormals. If you don't know normal, you don't know abnormal, and you won't be reporting it. Patient rights is a big one. Patient rights is a huge one. Never, ever, ever pick an answer that treats an adult like a child. So we don't restrict, we don't force, we don't insist, we don't do any of those things. Infection control, you have to understand infection control, and you have to understand safety as well. Those are the 5 things that they're really going to be testing you on the written test. I'm actually writing an ebook on this, and we're deep dives into questions on there. The whole question, each answer, it's a really deep dive ebook. It'll be available in a couple of probably a couple months. And but those are the big 5 things on the written test. On the skills test, you need to know the principles, and if you don't know the principles, head over to my website, foryourcna.com. Under CNA training, look at the animated lessons. You need to know the principles. It tells you how to do every single skill. And you're going to follow the care plan exactly. Whatever that care plan tells you to do for the skills, you're going to do. Exactly. As long as you do that, you'll be fine. You'll pass the test. Okay? And it's me, Danny says, can you please tell me what CNA means? Sure. CNA stands for Certified Nursing Assistant or Certified Nurse's Aide. It means the same thing, just two different ways of saying it. So we're nursing assistants. Hello, Laura. Maddie says, thank you for answering the question and for the good vibes. Well, we certainly wish you lots of luck on your test. Everybody that's testing this week, lots of luck. And Tanisha says, hi, it's Tanisha from Arkansas. I took my test in 2017 and I passed. Yay! A lot of people I know are trying and not passing since COVID Prometric shut down. Well, Prometric is back up and running. It's been running since June of last year, so that they should be able to test now. This site on YouTube was my guide for passing. Thank you, Tanisha. I appreciate that. We definitely appreciate all of you that have watched our videos and that tune into us every week as well. All right, guys. So let me give good vibes out to everybody that's getting ready to test, right? All the people that came in today and told us that they are getting ready to test. So we're going to keep our fingers crossed for you. And Lena's testing Saturday. Oh my goodness. This is so exciting. So please come back and let us know how you do. Just drop me a comment in any one of my videos. Not a reply to somebody else's comment because I don't always see those, but a fresh comment on any one of my videos. Drop me a comment. Tell me that you passed, and that way we can congratulate you on an upcoming episode. And actually, I want to congratulate Diane Horn, who passed and got her license reinstated. She was certified before, let it lapse, and now she's certified again. And that's happening a lot. I'm getting a lot of phone calls from people who let their CNA certification lapse, and now they're getting back into it, which is good because we really need CNAs. We got 2 people waiting on results. They've come by and let us know that they've either getting ready to test or they tested recently and they're waiting on their results. So we're going to send good vibes out to them too. Keep our fingers crossed to Mariah Knight and Captain Montague. What a great screen name. Helen says, good afternoon, Ms. Patty. Happy to see you again this Thursday. My question is about documentation skill. I tried to study pulse, urinary drainage, feeding, and I don't know how to document. Okay, well, for the test, it depends on what state you're in, okay? For the test, go to your state testing agency. So if you're testing with Prometric, go onto Prometric's website. Under Candidate Resources, they actually have the documentation forms right there so you can see, what they look like. But documentation is simply writing down what you measured. So as CNAs, for the test, all we're documenting are numbers, no words. There are no words for documentation. It's only numbers. So if you're measuring a pulse and you get 72, you're just going to write 72. If you're measuring respirations and you got 16, you would just write 16. If you're measuring the urine and got 600 cc's, you would write 600 cc's. So you're just writing numbers for documentation, and the form itself is very simple. It only has one thing on it, a line for you to write your specific documentation, whatever it is that you've measured. Okay? I hope that helps. When you talk of normals, what real is normals? Normal for blood pressure is 100 to 119 on the top or systolic, 60 to 79 on the bottom for diastolic. Pulse is 60 to 100. Respirations 12 to 20. Temperature 98 or 97.6 to 99.6 is considered normal. I'm not sure what normals you're looking for. Normal changes of aging, that's a whole book. I can't, unfortunately, go through all of that. Normal disease, normal things you would see in a disease process. Again, that's going to be in your CNA training. They should be training you on all of that. For feeding, there is no normal for feeding, right? Normal would be, whatever the patient normally eats. So if they eat everything that you're offering to them, it's 100%. If they ate half of it, it's 50%. If they took a couple bites, it's 25%. So it's, but there's no normal as far as eating, right? Because like me, normally I never finish my plate. I am not part of the Clean Plate Club. My husband finishes every single morsel on his plate. He is part of the Clean Plate Club every single time he eats. So that's normal for him, right? If he was eating and he only ate half of his food, now I know something's wrong with him because that's not normal. So it's not, there is no real normal for documentation as far as a global number. It's what's normal for the patient. Document feeding is simply percentage. Just like I went over, if they eat 100%, everything you give them is 100%. So documentation for feeding is just based on percentage. Now, if you have my book, the CNA Skills Study Guide, this book, if you have my book on page 72, or I'm sorry, 74, this is a feeding activity. This allows you to practice documentation of food percentages. And on page 120, 2, no, 120, sorry, 120. These are the documentation forms for pulse and respirations, feeding, and drainage bag. So the documentation forms are actually in my book. If you have it, it's a great place to go to take a look. And if you are in the online course, I have a whole bunch of activities on this as well. So if you haven't checked out the online course, you probably want to. If you have the book, those are the pages you would go to. If you're looking to see the book, it's on my website, foryourcna.com. Just click on shop and that'll take you to the book. It's called the CNA Skills Study Guide. All right, guys. Tanisha says, I just love how you explain you should travel and teach. Oh, thank you. It is my passion. Yes, it is absolutely my passion. This is what I live for every week. I love coming on here and helping you guys out. I want to give you the confidence you need to pass the test, but I also want to make sure that you have the right information, not for the test, but for the patients you're going to be taking care of after the test when you're actually working. Because someday I'm going to be the body in the bed, guys, and I want to make sure that you are going to treat me with the right amount of respect, with the right skill level. Make sure that you're protecting my privacy and my rights. I want to make sure that you're trained very well so that all of those patients out there are treated as if they were me. And I want to train you to keep that in mind. So that's why I do what I do. All right, guys. So everybody's asking where my book can be purchased. Just foryourcna.com. Click on shop, and CNA Skills Study Guide is what you want to look for. This is the cover. You'll see it. I've only got a few things on there, so I hope that helps. Well, thanks for tuning in, guys. This was a lot of fun today. And for those of you who are testing, great vibes. Let us know how you do. We're going to keep our fingers crossed for you. And we know that you're going to make fantastic caregivers. All right, guys, until next week, make sure you tune in next week. And if you haven't subscribed yet, please consider it because I'm trying to get my numbers up, and I never ask for subscribers. But if you could think about it, if I've given you any value, if you like it, you do me a favor and subscribe to me. So until next time, guys, I'll see you same time, same place, right back here Thursday at 3. Happy caregiving. Bye.